Assalamu alaikum. Good day to all of you, dear doctors. Today I am talking about an important topic for MRCS part examination. The topic name is jugular venous pressure. I think which is most important for MRCS part examinations. You'll find questions in every diet of MRCS examinations from here. Now I'm going to share my slides. We'll discuss terms about the background of jugular venous pressure. Exactly, the jugular venous pressure provides an indirect measure of central venous pressure. This is possible because the internal jugular vein, which connects to the right atrium without any valves. If you look into the diagram here, you find that the internal jugular vein which connects to the right atrium without any intervening valves, that's resulting in a continuous column of blood. The presence of this continuous column of blood means that changes in the right atrial pressure are reflected in the internal jugular vein. And as a result, raised right atrial pressure results in distension of the internal jugular vein. The internal jugular vein runs between the medial end of the clavicle and the earlobe under the medial aspect of the sternocleidomastoid muscle, making it difficult to visualize. Its double F1 pulsation is, however, sometimes visible due to transmission through the sternocleidomastoid muscle. Because of the inability to easily visualize the internal jugular vein, it's tempting to use the external jugular vein as a proxy for assessment of central venous pressure during clinical assessment. However, because the external jugular vein typically branches at right angle from the subclavian vein, unlike the internal jugular vein which sits in a straight line above the right atrium, it is less reliable. External jugular vein which is less reliable indicator of central venous pressure. Now we'll discuss about why do we assess the jugular venous pressure. Assessment of the jugular venous pressure can provide insight to the patient's fluid status and central venous pressure. If a patient is hypervolemic, the jugular venous pressure will appear raised due to increased venous pressure within the right atrium, causing a higher than normal column of blood within the internal jugular vein. Differentiating venous and arterial pulsation. When trying to identify the venous pulsation associated with the jugular venous pressure, it's important to distinguish it from the arterial pulsation of the nearby carotid artery. Difference between the venous pulsation of the jugular venous pressure and the arterial pulsation of the carotid artery include number of pulses, such as the jugular venous pressure has a double wave pulse, for example 2 pulse, whereas the carotid artery has a single pulsation for its cardiac cycle. Number 2, palpability. The pulse of the jugular venous pressure is not easily palpable, whereas the carotid pulse is typically easy to feel. The double F1 pulsation associated with the jugular venous pressure reflects pressure changes within the right atrium. Think of the pressure changes in the Mexican wave uh, starting in the right atrium and traveling to the internal jugular vein where we observe the pulsations. Now we'll discuss how do we assess the jugular venous pressure. Uh, Here some steps are followed. So number one, position of the patient in a semi-recumbent position at 45-degree angle. Here's the angles are found. And number two, ask the patient to turn their head slightly to the left. In the diagram, you'll find that the neck is slightly turned to the left. Number three, inspect for the internal jugular vein. running between the medial end of the clavicle and the earlobe under the medial aspect of the sternocleidomastoid. It may be visible just above the clavicle between the sternal and clavicular heads of the sternocleidomastoid. The internal jugular vein has a double waveform pulsations, which helps to differentiate it from the pulsation of the external carotid artery. Number four, steps each measure the jugular venous pressure by assessing the vertical distance between the sternal angle and the top of the pulsation point of the internal jugular vein. In healthy individuals, it should be no greater than 3 millimeters. Uh, should be no greater than 3 centimeters. Now we'll discuss about the hepatojugular reflex test. The hepatojugular reflex test involves the application of pressure to the liver whilst observing for a sustained rise in jugular venous pressure. This test can be used to further assess the jugular venous pressure, particularly if you are unsure if the vessel you are observing is the internal jugular vein. Eliciting hepatojugular reflex to be able to perform the test, there should be an at least 3 centimeter distance from the upper margin of the baseline of jugular venous pressure to the angle of the mandible. Position of the patient in semi-recumbent position, 45 degree. Apply direct pressure to the liver. Here's the apply direct pressure to the liver. Closely observe the internal jugular vein for a rise. In healthy individuals, the rise should be no longer than 1 to 2 cardiac cycles. It should be then fall. If the rise in jugular venous pressure is sustained and equal to or greater than 4 centimeter, this is deemed a positive result. This assessment can be uncomfortable for the patient and therefore it should only be performed when felt necessary. An examiner will often prevent you from performing it in an OSCE, but you should mention it. Now we'll discuss about the causes of raised jugular venous pressure. A raised jugular venous pressure indicates the presence of venous hypertension. Cardiac causes of raised jugular venous pressure includes number one, right-sided heart failure, number two, tricuspid regurgitation, and number three is constrictive pericarditis. In case of right-sided heart failure, commonly caused by left-sided heart failure, pulmonary hypertension is another cause of right-sided heart failure, often occurring due to chronic obstructive pulmonary disease or interstitial lung disease. In case of tricuspid regurgitation, causes include infective endocarditis and rheumatic heart disease. And in case of constrictive pericarditis, often idiopathic, but rheumatoid arthritis and tuberculosis are also possible underlying cause. Now we'll discuss about the jugular venous pressure waveform, which is most important for examination or in part examinations or ask examinations. The jugular venous pressure has its own waveform, which consists of 5 parts. Here so you'll find that A wave and X descent part on C wave and X descent part 2 and V wave, and lastly the Y wave, Y descent. The A wave is here's if you follow the A wave is caused by the contraction of the right atrium, where contraction of the right atrium, where blood is being pumped through the tricuspid valve into the right ventricle. Increased pressure in the right atrium also forces blood upwards towards and into the internal jugular vein. This influx of venous blood into the internal jugular vein is known as the airway. So we'll keep shortly discussion of airway and X descent, which is the first part of the X descent is caused by relaxation of the right atrium, which results in blood fleeing the right atrium from the superior vena cava, reducing the height of the column of blood sitting in the internal jugular vein. For example, causing a drop in the internal jugular vein, jugular venous pressure. The right ventricle's relaxation also contributes to the X descent as blood exits the right atrium into the right ventricle, further reducing the column of blood in the superior vena cava and internal jugular vein. Now we'll discuss about COF. The COF is caused by the forceful contraction the right ventricle which ejects blood out of the heart into the pulmonary artery. As this occurs, the pressure within the right ventricle increases significantly, forcing the tricuspid valve upwards so much so that it projects partially into the right atrium. This sudden project of the tricuspid valve into the right atrium generates upwards force which is transmitted into the superior vena cava and ultimately the internal jugular vein, causing a temporary rise in the jugular venous pressure referred to as the C wave. Now, which is X descent to part 2. The second part of X descent occurs during the final phase of right ventricular contraction when the ventricle is its most contracted state. It is physically much smaller than when in its relaxed state, resulting in the creation of extra space within the pericardium. This extra space within the pericardium allows the right atrium to expand and begins filling with blood. This initial phase of atrial filling results in a drop of venous pressure within the superior vena cava and inferior vena cava, producing the second part of the X descent. Now we'll discuss about the V wave formation. The V wave is caused by the relaxation of the right atrium whilst the tricuspid valve is still closed. The relaxation of the right atrium combined with a closed tricuspid valve results in blood being drawn to the column of blood that begins at the right atrium and extends up to the internal jugular vein. As blood is drawn into the column, whilst the tricuspid valve is closed, the level of the jugular venous pressure is temporarily increased. Now we will discuss about the last wave, which is Y descent. The Y descent occurs when the tricuspid valve opens, resulting in blood from the right atrium filling the right ventricle and blood from the superior vena cava and internal jugular vein filling the right atrium. This results in a decrease in the height of the column of blood and thus a decrease in the jugular venous pressure. I've shared some uh, conscious discussion about the waveforms. If you look into the diagram, you'll find that A wave, which is occurs due to the right atrial contracts, some blood is pushed back into the internal jugular vein. X descent is due to the relaxation of the right atrium, causing drop in pressure. CF, which is tricuspid valve closes and right ventricle contracts. X descent part 2, which occurs at the end of the right ventricle contractions, creates extra space within the pericardium, allowing right atrium to begin filling with blood. B wave, which occurs due to the filling of the right atrium against a closed tricuspid valve. Y descent, the tricuspid valve opens and blood from the right atrium begins to the fill ventricles. I have just discussed about the short diagrams such as pathological jugular venous pressure waveforms, which occurs due to Uh, Absent which occurs in atrial in case of atrial fibrillations, you find absent wave, and large waves are formed in case of pulmonary hypertension and pulmonary stenosis. Canyon waves are formed in case of complete heart block and ventricular arrhythmias and ectopics. Large waves are found in tricuspid regurgitations, rise in jugular venous pressure during inspirations, which is known as customer signs, which occurs in case of constrictive pericarditis. Uh, this chart is most important. Questions must come from the charts. Here's also another some pathologies are discussed, such as absence waves, which found in case of atrial fibrillation, sinus tachycardia, flutter waves, atrial flutter. Prominent waves are found in first degree atrioventricular block, large waves which found in tricuspid stenosis, right atrial myxoma, pulmonary hypertensions, pulmonary stenosis. Cannon waves are found in atrioventricular dissociation, ventricular tachycardia. Absent X descents are found in soft tricuspid regurgitations. Prominent X descents are found in conditions causing in large waves. Large C waves are formed in case of tricuspid regurgitation and in case of constrictive pericarditis. Slow I descents are found in case of tricuspid stenosis and right atrial myxoma. Rapid wide descents are found in constrictive pericarditis, severe right heart failure, tricuspid regurgitations, and in case of atrial septal defects. Absent wide descents are found in case of cardiac components. Here's the diagrams found about the in brief about the formation of jugular veins, such as A is formed in case of atrial contractions, X descent in case of atrial relaxation, CF is formed due to the tricuspid valve closure, X descent for passive atrial filling, BFs which occurs in case of maximum atrial filling, Y descent is found in atrial emptying. Here self finds another diagram, the cause of his pulsations. uh, I have discussed previously. Now I have shared mnemonics to remember about the wave formations, such as AF atrial contractions, CF isovolumetric contractions, XDC atrial relaxation, BOA venous return to atria, Y descent, atrial emptying. The mnemonics are here: AA, C, G, X, X, V, V, and YY. If we follow these mnemonics, I think in the exam hall it will be very easy for you to prepare about the jugular venous pressures. I think uh, I've discussed it jet of jugular venous pressures. I think all of you understand about this. If you have any questions or further questions, feel free to ask me.